Green.
Okay. So I came to the United States because of this man. I owe a lot for Dr. Wang. He's my lifelong mentor. I came here in 1999 and as a postdoc researcher and stay in the lab, start my own lab in the 2004, and we got a lot of the award. And that time I meet a lot of our faculty here. I started a residency in 2010. Dr. Abel and Dr. Chabra gave me the possibility to start the orthopedic residency. Really appreciate. This is my class. After the 2016, I went to the Columbia University to start a spine surgery. And I followed Dr. Linke. I think he's probably #1 spine deformity surgeon in the world. And Dr. Ru only do the cervical spine surgery and from the C2 to T2. That's the only surgery he do. And Dr. Lehman, he teach me about how to do the robotic surgery and the mini-invasive surgery. I came back, joined the orthopedics department in 2017. So right now we have the Dr. Shen, is our division chief. Yeah. And he is a graduate just 1 year after Dr. Chabra. Dr. Scheimer joined the orthopedics in 2009. And Dr. Singler did the 3 fellowship and joined the orthopedic department in 2014. And I've 17, and this year, August, we will get Dr. Lockie join us. We have the 3 spine PA and 1 nurse practitioner. Our spine fellowship, including all the adult spine surgeon and plus Dr. Bachman. We are growing. Last year we matched our 4th candidate, and this year we matched #1 candidate. So today I'm going to talk with you about a personalized treatment for the lumbar spondylolisthesis. This is my disclosure. Right now, we are getting the grant about $4 million from the NIH to do research on the disc degeneration, back pain, and leg pain. So lumbar spondylolisthesis is a very common problem. I know most of us do not do spine, but I want you know that after my talk, hopefully you can give the consult to your friends, to your relatives. So it's very common to the female than male, and it's common in the over 50 years old. And if it was spondylolisthesis, will cause the back pain and the leg pain. Back pain is because of the instability and the central stenosis, and the leg pain is caused by the central stenosis or foraminal stenosis or lateral stenosis. When we talk about the treatment, we have to bring up this classic article published in the New England Journal in Medicine in 2016. They compared the surgical treatment versus the non-surgical treatment for the spondy. And they found the patient with the surgical treatment have the great improvement in pain and the function. So what kind of surgical treatment? We usually categorize into the 3 groups. One is the decompression only. The other 2 is decompression with a fusion, either direct decompression or indirect decompression. Spondylolisthesis is not just one disease. There's the different phenotypes. Like some patients have the spondy is relatively stable. Some patients have the central stenosis. Some patients have the foraminal stenosis. Some patients lose the vertebrae body disc height. Some patients have L4 nerve symptoms. Some have the L5 symptoms. Some patients have the local kyphosis. And some patients have the disc herniation or facet cyst. And some patients have a lot of comorbidities. And you also have to put into consideration of the patient BMI, bone quality, and age. So we treat the different phenotype of the spondylolisthesis with a different method. I want to give you the 6 cases, and I want to introduce you the different treatment for just the simple disease, spondylolisthesis. The first case is a 61 years of the male with 90% of the leg pain and 10% of the back pain. Majority pain is falling to the L5 pattern. And in the X-ray, you can see there is a minimum slip in the L4 on top of the L5. MRI showed severe central stenosis. There's no spinal fluid protect the L5 nerve root. And there's no foraminal stenosis. So, and I think if we match the symptoms with MRIs, images, you can see the central stenosis will cause a lot of the neck pain, and the minimal slip probably cause the pain for the back. So what kind of treatment we should do? I will say probably all these kind of the 3 categories of the treatment can work for this patient. But which is the best one for him? Should we do the decompression only, or should we do the decompression with the fusion? There's a classic article published in the New England Journal in 2016 April from a group in the United States. They found that the cumulative rate of the reoperation in the decompression group is 34%, and the decompression with the fusion group is 14%. So their conclusion is the patient with the spondy should treat it with the decompression plus fusion. On the same year, same journal, and the same month, another article come from Sweden. They got a different result. They found the reoption rate is almost the same. So 21% for the decompression only group, and 22% decompression plus fusion group. So what's wrong? Why is it got a different data, different result? And we know that decompression surgery is popular in Sweden, but decompression fusion surgery is very, very popular in the United States. Is this because of the bias or because of the surgery itself? So when I look into the paper, we found that there's a different decompression technique. There is the traditional decompression, which is you move the spinous process and you move the lamina and decompress the central area, and you can see the dura during the surgery. So middle line structure is removed with the standard middle line decompression surgery. The other surgery is a non-invasive surgery. So you can decompress the central canal with just from the one side. You can do the laminectomy on one side and chew the tube and you go to decompress with the other side. The middle line structure is intact. And you can also do the endoscopic surgery. Even you can make a very small incision, probably 1 centimeter of incision, and you can do the same work. In the research published from the United States, they do the traditional laminectomy. So they after they remove the posterior structure, it will destabilize the bone segment a little bit. That probably cause more operation for the patient. There's a recent study published in the neurosurgery clinic and in North America, they found use the endoscopic surgery do the decompression. Only less than 10% of the patient need another fusion surgery. This is the meta-analysis study showed that decompression alone is not inferior to the decompression plus fusions group. But there is a higher rate of the worsening spondylolisthesis in the decompression only group. So what patient will develop more spondylolisthesis? There's research that there's a 3 risk factors. If there's motion over than 1.25 millimeter, or the disc height over 6.5 millimeter, or the facet angle is over 30 or 50 degrees, the patient, if they have this all 3 factors, the risk of the developed more spondylolisthesis is increased. So we go back to this patient. This patient have 10% of the back pain. Most of the pain is from the central stenosis. So I think the many invasive treatment for this patient is ULBD. So what we did is from the most symptomatic side, on the right side, I put in the tube and go to the decompress on this right side first, and then tilt tube and direct to the left side and decompress the left side. And you can see this is the image taken in the OR. This is the tube is from the right side, and I can use the curette and to go to the left side. Case number 2. This is 80 years of the male with 60% of the leg pain, 40% of the back pain. The leg pain following the L5 pattern. And the MRI and the CT X-ray show the grade 1 spondylolisthesis in the L4-5 with the severe central stenosis. And you can see when the patient gets the X-ray, here you can see the L4 flip on the L5. But when they get the MRI, you can see it perfectly reduced. The reason is that when the patient gets the X-ray, they are standing up. The gravity will pull the L4 vertebral body anterior. When the patient gets the MRI study, it will lying down. So the spondylolisthesis will reduce. That means the patient have some instability. That causes the lower back pain. So we think the leg pain is caused by the central stenosis, and the back pain, 40% of the back pain is caused by the slip. So when we talk about the different treatment, we also need to consider the patient age. This is 80 years of the gentleman with a lot of comorbidities. So all kinds of the surgery probably will help, and may not for just the decompression surgery, because 40% of the pain is from the back, from the instability. So we have to do the fusion surgery. But what is the shortest the fusion surgery? So for this patient, I did decompression for the L4-5 and used robots to place the 4 screws and putting the rod and subcutaneously. And we lay some bone in the lamina to fuse that segment. This surgery took me about 1.5 hours to do it. So the third patient, 51 years of the male with 50% of the leg pain and 50% of the back pain. And the 50% of the leg pain, majority is on the right side. And the pain pattern is going to the L4 nerve root as well as L5 nerve root. So we can see the X-ray, you can see there is the grade 1 spondylolisthesis, L4 on 5. There is a central stenosis on the L4-5. But this will cause the L5 nerve pain. But what's the reason the patient have a majority is on the right leg on the L4 distribution? So if we look at carefully, you can see there is the disc herniation on the right side at L4-5 level, far lateral disc herniation. a lot of people will miss that disc herniation. That is caused the patient for the right leg pain. So disc is just like jelly donuts. The jelly part is not exposed to our immune system because there's no blood supply to the disc. But when the jelly part getting out, our body will think this is a foreign body. We will send a lot of cells to attack it. In my lab, we developed a disc herniation model. We punctured the disc and got the disc herniation. You can see this is the disc herniation part. This is the injury of the disc part. This is the nerve. This is the sagittal cut. And you can see a lot of the inflammatory cells around the disc itself and also the nerve. So we did it immunostaining, found inflammatory marker, interleukin-1 beta and interleukin-6 is highly expressed around the disc hernia site as well as around the nerve. So we think the pain in the nerve is caused by the inflammation. So let's go back to the patient. If we want to match the symptoms with the images, we know that the disc herniation in the right far lateral is called the right L4 nerve pain. The central stenosis is called L5 nerve pain. And the instability here caused the lower back pain. So how do we treat this patient? We can treat with the decompression, but the 50% of the pain is from the back. There is the instability here. We can treat with the indirect decompression, but the problem is we could not address on the disc herniation here, because we do not remove all this inflammation tissue. After the indirect decompression, all the inflammation tissue is still irritated nerve. The patient will still continue to have pain. So what's the best treatment? The option will be the direct decompression. We want to see the nerve. So there are two approaches. One is the minimally invasive approach. The other is traditional open approach. For this patient, we know that minimally invasive approach will have smaller incision, will have decreased blood loss, will is muscle sparing, and also decrease length of the hospital stay and decrease the risk of the infection. There's studies show that minimally invasive XLIF is more cost effective than the open XLIF. So for this patient, I did the minimally invasive procedure. We make the incision on both sides. We put in the screws, and then we cut the inferior facet of the L4 and the superior facet on the L5 on the right side, expose the disc herniation, and we see the nerve directly and remove all the inflammation tissue around that nerve. And then we put in the cage in addition to the decompress the L5 nerve root. So after the surgery, the patient pain is totally gone on the right leg. So the fourth case, this is the 50 years of the female with 70% of the left leg pain, 25% of the back pain. It's big patient, most of the pain is on the left leg. And you can see it's the grade 1 to 2 spondylolisthesis, L4 on 5. When we get the flexion and extension X-ray, you can see there's the more slip when the patient got the flexion because of the gravity will pull the disc forward. And when we do the extension X-ray, it will reduce a little bit. So MRI showed there is the central stenosis, but there's also a facet cyst. You can see the white color, that's the synovial fluid joint. And this is a facet cyst and compress on the nerve of the L5. And also there's the foraminal stenosis in the L4-5 compress on the nerve of the L4. So we got CT scan, you can see the joint is completely open and destroyed, and you can see there's this is L4, this is L5, there's a big gap here. And this patient is a BMI is 40, 45. So what kind of surgery we should do? So we think if we match the symptoms with the images, we know that this is a flexion X-ray. You can see the grade 2 spondylolisthesis. When the patient lie on to get the CT scan, short time, it's reduced to the grade 1. When the patient is lying on the table for the MRI, even longer time, is reduced more. So that instability will cause lower back pain, and the facet cyst and the foraminal stenosis cause the leg pain. So we could not do the decompression surgery because the slip, and we could do the indirect decompression, but you could not address on the facet cyst, right? And also, you could not feel the facet joint very well because the facet joint is wide open there. So the next option will be the direct decompression to remove the facet cyst. There's the two kinds, MS surgery or the open surgery. And we need to consider that it's a big patient, BMI 45, and young patient, 50-year-old. If I do the MS surgery, I do not trust I can do a very good job to give the patient enough bony surface to fuse that big patient. So for her, I did the open XLIF surgery, and during the surgery, we removed the facet cyst, and we decompressed the L4-5, and removed the facet cyst joint, and putting the autograft and bone to fuse the facet joint, and putting the screws and rod and putting the cage. So number 5 case. This is a 60 years of the female with 15% of the leg pain. Majority is 85% of the lower back pain. And in the X-ray, you can see the grade 1 spondylolisthesis, L4-5, is reduced when the patient do the extension and getting worse when the patient in the flexion. MRI showed the facet effusion, but there's no much of the stenosis. And you can see clearly here there's a grade 1 spondylolisthesis, but completely reduced when the patient get MRI. So if we match the symptoms with the images, we know that most of the pain is from the spondylolisthesis, and some of the leg pain probably caused by the irritation of the nerve. So what kind of surgery? Decompression only probably would not work for her. She's young, and she is have the high disc, and also she have the instability. So how about the direct decompression, like the last patient? It probably will not work very well because the patient, there's no severe stenosis. You do not need to do a direct decompression for this patient. The most patient problem is from the instability. So we consider indirect decompression and fuse the spine. So we can do either XLIF or OLIF. In the XLIF, we can put a very big cage. This is the XLIF cage. You can see it's about 1/3 surface of the XLIF cage. When we put in the bigger cage, bigger bony surface, it will get more excellent fusion rate. And the XLIF also can do the indirect decompression. But everything have the good side and bad side. The disadvantage of the XLIF is because, like, this is a nerve, this is the lumbar nerves. Most of the spondy is happened in the L4-5 disc, and it's very close to the nerve. And some patients after the surgery, they will have psoas weakness or the cutaneous nerve issue. And also not every L4-5 disc can be done with the XLIF surgery because of the pelvis, the iliac crest. And if you do want to do the posterior fusion, you have to change the position for the patient. So another choice will be another thing is if the patient have transitional anatomy, like this patient, this is the psoas muscle, just like Mickey's ear. So when the psoas muscle pull forward, they will pull forward the nerve. The XLIF, the approach is from here. So you have the more chance to injure the nerve. So how about the OLIF? The OLIF have all the advantage of the XLIF, but do not have the disadvantage of the XLIF. And because we go from the front, we go from the corridor between the psoas muscle and the alta here. So we do not violate or do not injure the psoas muscle. In addition to that, we also can do the single position surgery, which is we can just place the patient on the side and putting the screws and putting the cage when the patient just in single position. We do not change the patient position. So it will significantly save the time and less radiation because we use robots and it's accurate and many invasive surgery. And robots also can limit the learning curve. And there's an article published and showed OLIF is better than the TLIF. So for this patient, we place the patient in the side position, left side up. This is the head, this is the buttock, this is looking at her back, and this is looking at her front. So we're putting the screws and the screws first with robots, and then I will go anterior to putting the cage, and then come back to the back and putting the rod. Josh is my favorite resident to do the OLIF procedure. We do a lot. So this is the outcome. This is the surgery. So we're putting the cage and putting the rod and screws and fixed her, stabilized her L4-5. The last case. So this is a 51 years of the female with left leg pain, 25% of left leg pain, and 75% of the back pain. And X-ray showed there is the scoliosis in the lumbar spine, and also grade 1 slip in the L4-5, and a little bit slip in the L5-S1. You can see there's this moderate central stenosis in the L4-5, and the L5-S1, there's the right side stenosis, but most of the patient is complaining about the left leg pain. So this level probably not caused her back pain, leg pain. So if we match the symptoms with the images, we think the instability will cause 75% of the back pain, and 25% of the leg pain is caused by the stenosis. So what kind of surgery we can do? Yeah, we can do the TLIF, L4-5 or L4-S1 TLIF. But TLIF surgery, some people will call it kyphosis surgery because we could not put in a big lordosis cage. And some patients, after that surgery, if you fixed into the flat back, the patient will develop adjacent level problem. And also, we also need to consider that this is a young patient, 50-year-old. This patient also have the scoliosis. And probably this will be not her last surgery. And probably she needed another surgery, T10 to pelvis surgery. So for this patient, can we do the OLIF? It's hard because there's the corridor is very, very narrow. So this is the psoas muscle, this is the alta. This is a very narrow corridor to go to the 4-5 disc. So for this patient, I did the XLIF, L45 and L5S1. I just want to build a very solid foundation for her next surgery. And also the XLIF, you can give her the very good lordosis. So the take-home message is that spondylolisthesis is not just one disease. There's different phenotype. It's not like a knee osteoarthritis. Only one surgery, right? Knee replacement. That's it for the elder patient. But with one spondylolisthesis, you can treat with a different surgery. And you just need to tailor their symptoms with your surgery. So every approach have the good side and bad side. MS surgery is decompression is preferred if the symptom is most of it is a leg pain. It's caused by the central stenosis. If the patient have the disc herniation or the facet cyst, probably you can consider MS TLIF to direct decompress the spine. XLIF and OLIF is good for the patient or just need indirect decompression and fusion surgery. XLIF is very good for the patient. You want to get the lordosis and you do not violate the posterior structure. In addition, because the patient needs surgery, more surgery in the future. Okay, thank you for your attention.